Hello and welcome back. This is Jonathan Schwartz here at Cardiovascular Innovations 2023, coming here from Austin. I'm here with Edoardo Zancanaro from San Raffaele. Welcome. Good to have you here. So you're a cardiac surgeon, and just tell us a little bit about your training and what your interests are and what you're going to be doing here today.
Thank you. First of all, thank you for this opportunity. Yeah, this is a really interesting question because several people here talk about the things that in America compared to Europe, for example, cardiac surgeons are more involved in my country, for example, in the structural procedure. Actually, it depends really on centers. In San Raffaele, there is the valve center in which Professor Maisano is the chief and is really willing in transcatheter procedure. So in my residency program, we are not only scrubbing in the classical cardiac surgery procedure, minimal invasive and so forth, but also in transcatheter. Mostly, of course, the structural ones, so TAVI or all the mitral procedure, not only the TEER, but also the TMVR and so forth. This is really important, I guess, because the new generation of surgeons have to be more involved in this percutaneous treatment, absolutely. So for us, it's a huge impact because we know that some surgical procedure, like, for example, aortic valve replacement, probably will be totally replaced in the future, so we need to embrace this word.
Of course. Does that extend your training at all, or how do you balance the need to get both your surgical skills and your transcatheter skills, up to par?
Yeah, this is a really important point. Actually, it is difficult for us to be good at both things because the learning curve for surgical procedure is kind of slow, and so we need to do two specialty in one. What we do is just we share times, like in the classical and in the hybrid OR. It's really complex because you need to do both things, and you need to have at least a lot of time. But it's something that at the end it will be really worth it.
Of course. Well, you're in good hands with Dr. Maisano.
Yeah,
sure.
Absolutely.
So I know you have a great case for us. So tell us a little bit about what you'll be showing.
This case is a first human case, because this patient was treated with tendine with other different operation that she previously underwent. In 2 years from the implants, we saw a degeneration not of the valve per se, of the tendine per se, but of the outer frame. So there were no paravalvular leak, no leaflets problem, but the outer frame of the valve was degenerated. This is the first case ever seen. We manage it with what we call the Sapien Dyne, which is the new name, which is a Sapien 3 valve ultra, but customized. So we cover all the valve with a PTFE strut in order to implant in the tendine very ventricular. So we block the two jets that was coming from the ventricle, actually. During the procedure, we had a naturalization of the first valve, so we put another valve because, of course, the tendine is not really helpful in this kind of sense.
Right.
But with two Sapien, with this customization, we end up in closing the two jets, and now the patient is really fine at 6 months of follow-up.
That's great. When you put the second one in, did you also have to put PTFE around, or how?
Yeah.
Did?
Also in the second one, just to be sure, because the first one lateralized a little bit, so we put another one again more distal. But we had to customize that as well. Actually, we use the ultra valve, so because we have seen that the skirt was higher in the ultra rather than the Sapien 3, the previous one. So we use the ultra for this reason as well.
And did you go transapical to deliver?
No,
it,
transfemoral.
Was all
Transfemoral with. We perform a transeptal puncture, and we use a septostomy to make the septum all bigger, and we use also a body balloon in order to help the valve pass through to the septostomy. In fact, we use 2 Safari wires in the ventricle to have both wires ready to have a body balloon also for the tendine.
Of course. It's interesting. So I know at our center, and it's a little bit popular, I wouldn't say popular, but it happens where the only option is to go transapical, and so sometimes we've put, like in MAC cases, put a Sapien in and sew some PTFE around it. Do you also do that at your center, or is that?
Not for the MAC, but I've seen. We are never done this before, but I've seen the things that there was also an article about it, of covering in order to reduce the paravalvular leak in case of valve-in-valve mitral. So
Okay, well, so last question. We're getting to the point where we're learning a lot about mitral valves. There's many transcatheter options on the market. I know you have access to a lot at your center.
Yeah.
Do you have a favorite? Do you see one coming out that you like? Is there maybe a few that you think are going to be winners? What are your thoughts on that?
First of all, it depends, of course, on the pathology of the mitral valve. Actually, we use, of course, a lot of tear with different device for clipping the valve. In case in which we need to put a valve, we use a lot of Tendyne. To be honest, we have a really good experience. I following personally the results of the Tendyne, which are really nice compared to the patient, for example, that are refused for all different reasons that we know. But also the sapien in case of valve in valve or valve in ring, it's a good option. So this is most of the device that we use. Of course, depend on the pathology.
Of course, great. Well, Edoardo, great to hear you. Always good to see you. Good luck in the competition.
Thank
We'll see
you very
how
much.
you do.
It was a real pleasure.
Thanks for watching. Stay tuned for more from CVI 2023.